Yes.
Okay. Okay. So hi everyone. Today I'll be presenting a case on, okay, it's a case. Basically the patient was admitted for 4 months. So I have tried cutting down the visits into 3 different visits. So in order to engage everyone in the presentation, I'll be asking questions every now and then. Feel free to answer in the chat box or you can answer me directly. That's okay. So I'll begin with the presentation. Okay, so a 12-year-old boy came with complaints of headache, intermittent vomiting since 1 month with decreased movements of right upper and lower limbs. This was associated with right deviation of the mouth, and hence the patient was admitted to the hospital. On examination, it was noticed that he had relative bradycardia, right hemiparesis, right 7 upper motor neuron palsy, neck stiffness, and decreased deep tendon reflexes. So far, what is your impression? Anyone? The patient has headache and intermittent vomiting since 1 month. Any impression? Okay, I'll go ahead.
It can be mass, intercranial mass, or like like something like that. Initial evaluation, yeah.
Okay, thank you. Okay, so the patient was advised to undergo MRI and gastric lavage sample was sent for acid fast staining. It was sent twice and both the time it came back negative. So now I'll be showing you the MRI. So this is the lesion which was, yeah, 1 second. Let's just not arrive to the diagnosis. So we're seeing some sort of a mass in the left side of the brain if you're able to follow the pointer here. Okay, let me just read out the MRI impression for you. The MRI impression was left conglomerated and focal intracranial tuberculomas. So then the patient was managed for increased intracranial pressure and he was prescribed with first-line anti-tubercular drugs and IV steroids on the basis of MRI findings. And then subsequently, the patient was discharged after 5 days, noting an improvement in his overall power. He was prescribed with first-line AKT and oral steroids. However, the patient came back again with 12-hour complaints of headache, vomiting, and lethargy. So on admission, it was noted that his blood pressure was 110/60. His Glasgow Coma scale was 15. He was conscious and alert. Pupils were reactive, and please note that there was no fever associated. So at this time, again, we treated the patient for increased intracranial pressure with AKT and steroids. Again, the patient was referred to MRI. And at this time, we noted that there was an increase in the ring enhancing lesions in the left corona radiator, and few new ring-like lesions were noted in the right corona radiator as well. So we can see that it had progressively grown from the left part of the brain to the right. So then the child was intubated and he was kept on ventilator. Decompression craniotomy with external ventricular drainage was done, and the sample which was collected was sent to the histopathology lab. The sample was also preserved for further investigation. Now, meanwhile, the patient had developed fever spikes, developed right hemiparesis, spasticity with hypertonia, clonus, and raised intracranial pressure. So where do we normally see clonus in a patient? Like what has to be involved in order to see clonus?
Upper motor.
Okay. Okay. Then post-op CT brain was done, endotracheal tube secretion was collected, and blood cultures were collected from the central lines. Those were sent for investigations, and again, we didn't see any growth in those. The patient was then extubated after noting slight improvement after 6 days. However, he continued to have fever spikes. Now, CT was suggestive of significant perilesional edema in the left frontoparietal temporal lobes, causing mass effect, like someone had earlier suggested. Few other hyperdense lesions were seen in the left frontoparietal region and in the right corona radiator. The hyperdense lesions had multiple air foci within. The histopathology report came back and on microscopy it was noted to have caseous necrosis. granulomas of epithelioid cells with many Langerhans giant cells and chronic inflammatory infiltrate. So caseous necrosis is typical in which particular lesion? Okay, so the impression was the features were consistent with granulomatous lesions, and most likely it was a granuloma. Further course of the patient, he developed right upper and lower limb spasticity, right hemiparesis, impaired cognition, and syndrome of inappropriate antidiuretic hormone. So I think this could be a discussion for later on, like how intracranial, increased intracranial pressures are associated with SIADH. And then no head holding was noted in the patient. Again, the MRI was repeated and tuberculomas were increasing in size and number, and the tubercular abscesses were also seen in most of the lesions. So at this stage, the further management included, we had to collect patients' sputum for acid fast bacillite stain and gene export, which is one of the best tests to detect the tuberculosis. The patient was advised to undergo chest X-ray. Gastric aspirate was taken for acid fast stain twice. All the reports came back negative. But CSF report, the chemical examination was suggestive of increased protein, 240 milligrams per DL, and slightly decreased chloride levels. So at this stage, what is your differential diagnosis? We are noticing an increased protein levels. Anyone?
Bacterial.
But the glucose is low. Okay, let's go with that. But the gram stain and acid fast bacillite smear stain, no pathogens were detected. So one of the consultants suggested that we add second line AKT. So we added chloramphenicol. Surgical exploration for abscess drainage was ordered. At this stage, our provisional diagnosis was intracranial tuberculoma with encephalopathy. The patient continued to progressively deteriorate. Then, since we were collecting samples every second day, on one day, we saw that the urine sample was suggestive of yeast cells, and hence we decided to add an antifungal agent, that is fluconazole. So though mild improvement in tone and activity was noted, the Glasgow Coma Scale score was still at 8. The child then developed decerebrate posturing and seizures. So I want to ask at which level of the brain is responsible for decerebrate posturing? We all have read this.
Brainstem.
Okay. And then MRI was repeated. Okay. So on repeating, one second. Okay. On repeating the MRI, it was suggestive of vasogenic edema with increased lesions in the right cerebral hemisphere and herniation of left cerebral parenchyma. At this time, we were suspecting Mendelian susceptibility to mycobacterial disease. This is like one of the rarest syndrome, which is actually due to exposure to poorly virulent mycobacteria, or it could also be a result of BCG vaccines, which is one of the rarest causes. So since we were suspecting this, we went ahead with diagnostic tapping, CSF PCR, fungal culture and staining were ordered, bacterial culture were ordered again, and then we also referred for gene expert. On examination, however, we noted that the patient had unequal pupils with ptosis, decerebrate posturing, hypertonia, raised intracranial pressure, and jerky breathing. Hence, the patient was re-intubated and tracheostomy was done. At this stage, we were considering extra drug-resistant TB protocol. Now, if you remember, we had collected the abscess sample earlier. So this previously collected abscess sample, which was drained from the craniotomy site, was sent again for bacterial and fungal culture, gene expert, and MGI, that is mycobacteria growth indicator tube. So this test is done in order to see whether the bacteria grows in the presence of certain drugs or not, just to check the bacteria's resistance or drug resistance or sensitivity. However, all the reports came back negative. But 2 days later, fungal culture report came back positive for one of the rare fungus called Cladophylloflora bantiana. But unfortunately, the patient developed hypotensive septic shock with raised intracranial pressure, and he succumbed to his illness the next day the very next day when we got the fungal cultures back. So what do we know about this fungus? So intracerebral Cladophyllophora bantiana has got 70% mortality rate despite advances in surgical resection capabilities and the use of systemic and intrathecal antifungal treatments. Now this fungus is prevalent in tropical countries owing to the high temperatures. The fungus lives in soil, vegetations, and infects humans via inhalational route or through puncture wounds. And CSF fungal infections are mainly because of hematogenous routes or from air, sinuses, or bone. And this fungus is known to be neurotropic. It grows on routine fungal culture media like potato dextrose agar, oatmeal agar, and malt agar. And the strange thing is this fungus has a predilection for immunocompetent hosts, unlike the other fungus, which are found mostly in immunocompromised hosts. The clinical presentation of patients with cerebral hyphomicrosis may vary, but most often presents with features of raised intracranial pressure, something which we've noted in this case. Radiologically, the intrafungal cerebral abscesses are known as a great mimickers and may be difficult to distinguish from high-grade gliomas, lymphomas, or Mets cancer. This fungus often results in supratentorial growth, with the majority of reported cases growing in the frontal lobes. Contrast-enhanced images show an irregular heterogeneous lesion with mass effect and significance surrounding vasogenic edema, something that we've noted in this case as well. Successful treatment depends on accurate microbiological and histopathological information for identification of the fungus and initiation of personalized targeted antifungal treatment. Though we have new generation triazole antifungal treatments, the basic challenge is the diagnosis of the fungus and treatment at the appropriate time. And that's it. This was the case, and thanks to everyone for listening.